My name is Peter Forsberg. I'm an assistant professor at the University of Colorado and a specialist in myeloma and other plasma cell diseases. So is there a cure for my multiple myeloma, or will I always need to be on treatment? And what is my overall prognosis? I think these are some of the most important questions that patients can ask when they're newly diagnosed or at different points in their myeloma treatment, to sort of get a sort of foundational understanding for their myeloma and sort of try to understand it the way that their oncologist does. It's a tricky question because as of the year 2021, we still think of myeloma as largely an incurable disease, a disease that, based on some of the unique biological characteristics of plasma cells, which are the cells that give rise to myeloma, is susceptible to come back in the future, to relapse. And that the potential for that is can be a little bit hard to predict. So that being said, there are a portion of patients who achieve very stable long-term control of their disease with the tools that we currently have available to us. How we define cure in multiple myeloma has been a challenging discussion for the myeloma community as we try to identify and sort of, I guess, label our patients who have the best possible outcomes to our treatments. But we still anticipate the potential for patients' myeloma to come back, even after very substantial periods of disease control sometimes. So even though myeloma may not be considered a consistently curable disease, currently, it is one that we are able to control much better than we ever have been able to historically. We do that by using an ever expanding myeloma treatment tool bag. We have a number of different medicines that work, and they work in somewhat different ways, and we try to leverage those to achieve control of myeloma, and then to try to use the best tools we have to sustain that control. That may mean intensive tools like stem cell transplant, or it may mean less intensive tools like reducing your regimen to a maintenance-based treatment that tries to reduce potential side effects and toxicities, but allow patients to stay on some degree of anti-myeloma therapy in a very sustained, open-ended way to try to continue to have disease control. So I think we use a lot of our tools in variable ways to try to achieve and maintain control as best we can, while also trying to preserve quality of life, which I think is a key consideration for us in the modern era as we have more and more tools at our disposal. So I guess I'd say that, will I always need to be on treatment is a challenging question because there are no always scenarios in multiple myeloma. It is a very diverse situation. What we do in some countries is different than in other countries, and that may be based on drug approvals and availability. Different providers have slightly different philosophical or approaches, but I would say that we have moved into a treatment paradigm where there is more focus on control, on sustaining control, finding ways to be able to optimize that. And that does often lead to us being on some degree of therapy for very substantial intervals of time after diagnosis with myeloma. I think the goal is always to sort of modulate our treatment in the most thoughtful possible way so that when there are times where we can reduce or scale back our treatment to reduce those side effects, that we do find ways to prioritize that. But knowing that other times are likely to come where the myeloma will become more active and often need a more robust or multi-agent treatment approach to then gain and sustain control. In terms of overall prognosis, I think that's something that, we've made great progress with. The majority of patients with myeloma are living longer and longer than they have historically, and that continues to evolve. Every time we take a look backwards, we find that our averages have increased. So that leads to many patients with newly diagnosed myeloma living an average of more than 10 years even. Now, it's kind of a complex question because myeloma doesn't happen in a vacuum. Myeloma occurs in somebody, and the average age for diagnosis of myeloma is around 70. So many of the times, people with myeloma have other medical issues that they are dealing with, either at diagnosis or at some point in their myeloma journey. Beyond that, we're somewhat limited because averages are just that, they're averages. So whenever we're talking about prognosis, we're always talking about estimates and sort of averages, and there can be diversity. There are still unfortunate situations where myeloma can behave aggressively and where patients may end up with less stable control of their disease, and a prognosis that's not in line with those averages. And those are situations that we still need to work on to try to improve our treatment approaches in the way we deal with those scenarios. Beyond that, whenever we look at prognosis, we're always looking backwards. So I think even if you were to find information that sort of says this is the average with myeloma, we're always looking at what was being done when those patients who we read out the average on were diagnosed 5 or 10 or 15 years ago. So it's been a bit of a moving goalpost in terms of how we predict averages for prognosis. I think even beyond the fact that patients are living longer with myeloma than they ever have before especially on average, patients are living better. So one of our great successes is not just that our treatments are able to allow people more longevity, but they're able to allow patients to live longer with better quality of life, fewer treatment-related side effects, preserving people being able to do the things they care about doing, and maintain quality of life, even though they may end up needing to be on treatments fairly consistently for very long intervals of time.